A very warm welcome to all of you to this evening's webinar. Um, we are going to focus on anaphylaxis. So anaphylaxis collaborating for improvements in care. And if I can have the next slide, please. This is just merely to remind you it's sponsored by ALK. So the breaking news tonight is that Boris, our Prime Minister, has postponed his announcement. Obviously, he knew that you'll all be dialing into this meeting, although it's probably the most leaked announcement we've had during the whole pandemic. So you can focus on a great lineup that we have this evening. So if I can have the next slide, please. So I need to just remind you about the question. So you can ask questions at any time through this evening using the questions tab. If it's disappeared, it's hiding behind your video screen because you've maximized it. So just minimize it and you'll find it. There will be certificates of attendance, and it would be great if you complete the online survey afterwards. So next slide, please. So what I wanted to do just at the up front is just use this as an opportunity to just frame things with recommendations that are going to appear hopefully in a few months' time. The IACI anaphylaxis guideline is complete. Many of you will have seen it when it went through the public review stage, and these are the recommendations you will remember. You all obviously are interested in anaphylaxis, know it's important, and so I think these will be helpful to you. So we'll emphasize the prompt use of intramuscular adrenaline as first-line management. Patients at risk of anaphylaxis having access to adrenaline in the community. We looked at all the pharmacokinetic data, and actually it's quite variable for the different devices, and we feel actually that should be provided by the companies. We talk about having a structured, comprehensive training program for people at risk of anaphylaxis, and emphasize that actually simulation training and visual prompts are really helpful for healthcare professionals who need to potentially manage it. And then in terms of school, emphasizing that actually school policies should reflect anaphylaxis guidelines. So looking forward to seeing that properly in publication, hopefully in a few months' time. So if we can go on to the next slide, please. So this is tonight's agenda. We've got three excellent presentations. The first is by Antonio Moraro, who's a professor of food allergy in Padua in Italy, who's really led food allergy and anaphylaxis activities across Europe and much of the world in the last 10 years. And she's going to talk about living with anaphylaxis and how we support patients with guidelines and beyond. Then Pam Ewing from Cambridge, one of our consultant allergists, is going to talk about how we support our primary care colleagues with at-risk patients. And then we move to Matt Doyle, who's a GP with a special interest in allergy from Jersey, who's going to look at patients at risk of anaphylaxis in primary care and provide the other side of the coin for that. So, and there will be lots of time at the end for questions and answers. So if I can go to the next slide, please. So one of the recommendations that came out from the European Medicine Agency a few years ago when they were looking at why people were still dying from anaphylaxis was that we must provide better training for patients who have self-injectable adrenaline. And all the companies were asked to develop educational things that can be used by patients. And what ALK have done is chosen to develop an app. And this addresses quite a lot of the areas that we know are problems for our patients from the guidelines we've recently written. So we thought we'd just show the app at the start of this meeting before we go to Antonella for the first presentation. So if we can just
Introducing the Jext app. The free Jext app is especially designed to support Jext patients 24/7 with useful on-the-go features. Most importantly, it offers immediate support should you need to use your Jext. Just click on Use My Jext Now and the app will give you step-by-step audio and visual instructions for administering Jext in an emergency. Grasp the Jext with your dominant hand, with your thumb closest to the yellow cap. Pull off the yellow cap with your other hand. Place the black injector tip against your outer thigh, holding the injector at a right angle, approximately 90 degrees to the thigh. Push the black tip firmly into your outer thigh until you hear a click, confirming the injection has started, then keep it pushed in. Hold the injector in place against the thigh for 10 seconds, a slow count to 10, then remove. Jext has been designed to inject through the clothes, avoiding zips and buttons. The needle shield will automatically cover the needle when the Jext is removed from the thigh. Massage the area for 10 seconds. Immediately dial your local emergency number, 999 in the UK or 112 in Ireland. Ask for an ambulance and say anaphylaxis, even if symptoms appear to be improving. If you are not feeling better, or if you begin to feel worse, a second injection with a different Jext can be administered 5 to 15 minutes after your first injection. Following the demonstration, the Jext app provides a GPS location and prompts you to call 999 in the UK or 112 in Ireland. It is important that you know when your Jext expires to give you adequate time to source a new Jext. You can register with the Expiry Alert Service to receive a free alert warning when your Jext is due to expire. You can choose to do this through text or email or both, and you will be notified 4 weeks prior to the expiration of Jext, 2 weeks prior to the expiration of Jext, and on the day after the expiration of Jext. Here, you can also order a free Jext training device to enable you to practice using your Jext safely. There is also a second option to order a Jext trainer pen here. You can watch Jext demonstration videos, including how to use your Jext to help familiarize yourself and your friends and family on what to do in the event of an anaphylactic reaction. We have one for adult patients and also videos for kids and for teenagers. Within the Jext app, you can generate your own custom image with vital information to use as a locked screen wallpaper for your phone, including your allergy, your emergency contact, and where you keep your Jext. The image is then generated and saved straight into your phone's photo gallery, where you can set it as your lock screen in case of an anaphylaxis emergency. Support with Jext does not stop at the UK border. The Jext app provides phrase sheets to assist you during foreign travels. Our phrase sheets contain translations for useful phrases relating to food allergies. They are available in 26 different languages. Simply select the country you're traveling to, select the allergen you are allergic to, and either read, show, or press for audio to translate clearly your allergy. This can be downloaded prior to your trip to eliminate the need for Wi-Fi or cellular coverage during your visit.
Ich bin gegen Erdnüsse allergisch. Sind in diesem Essen Erdnüsse enthalten? Ich darf nichts essen, das Erdnüsse enthält.
If English is not your first language, or that of your immediate friends and family, you can access an action plan in many different languages to ensure everyone is able to understand how to use your Jext. Just select from the list the language you need, and it will download immediately. It can be printed, saved, or emailed from here. When flying, you should carry Jext with you at all times. You may need a travel certificate to take Jext with you abroad. It is important to fill this in and ask your GP to sign it before you go. The Jext app offers other support. You can find extra information about your Jext and get help with frequently asked questions. When downloading your Jext app for the first time, you will be prompted to set reminders for periodic training refreshers, checking the inspection window of your Jext, and registering for expiry alerts. These reminders can be scheduled at weekly, fortnightly, monthly, quarterly, 6-monthly, or annual intervals, and will appear as a notification to your phone at these set times. Downloading in a rush? All of these features can be accessed again later, here. In an anaphylactic emergency, vital treatment information can be hard to remember or tell someone about. The Jext app makes injection instructions, guidance, and expiry alerts just a tap away. Download the app by searching Jext in the Apple or Google Play stores.
So I thought that video, the app was actually very helpful, and it's something I'm certainly going to be alerting my patients to. So at this juncture, I'm going to invite our first speaker to give her presentation. So Antonella Moraro, Professor of Food Allergy from Padua in Italy, is going to tell us about living with anaphylaxis and specifically supporting patients with guidelines and beyond. Thank you very much, Antonella.
Thank you very much, Graham. I would like to thank very much the chair and the organizers for giving me the opportunity to share with you some thoughts on how to best support a patient suffering from anaphylaxis, implementing evidence-based guidelines daily in real world. These are my disclosure, and I will go briefly through what does it mean to live with anaphylaxis, the burden for patient, but also the load for stakeholders, and most importantly, the lack of an harmonized approach. Understanding the risk of anaphylaxis means to tailor treatment around each patient, and this means understanding and profiling each patient at risk of anaphylaxis. There is a need to improve adherence and safety, and the guidelines would help us in this regard. And I will provide also a vision of an integrated care pathway for anaphylaxis that is going to be implemented at the Global Allergy and Asthma Network of Centers of Excellence Centers, so-called AnaCare Centers for Food Allergy and Anaphylaxis. Patients with anaphylaxis suffer for a constant load of living with a constant fear of a severe reaction due to incidents of accidental exposure to food, 10 up to 25% per year, being a food allergy the first cause of fatal anaphylaxis in children, and not having predictive markers for severity of the reaction except severe asthma. And this force them to have a preventive measure implemented all days, all time, impacting hugely their quality of life. And the bad quality of life of this patient resulting from lack of health, lack of leisure activities, of life satisfaction, social interaction, means that the disease is not a burden in the physician office for diagnosis and treatment, but it is a social burden impacting global health perception and ultimately in the social identity. And this is also on the rise, as this payers report showed in 2017 at a Fair Health, which is the fair of insurance companies in the US. And you can see here that the claim lines with diagnosis of food anaphylaxis raised by 15% in 10 years from 2007 to 2016. Medical and community fragmentation hugely influences the lack of standardized diagnostic and treatment pathway across Europe, and also the difficulty to recognize symptoms and, most importantly, the severity of symptoms which prompt to the administration of self-injectable adrenaline. Primary care are dealing with that, but this is not their priority, and they should receive more instructions and training on how to best recognize this patient at risk. And politicians should be more aware of what is needed in terms of legislation. So, as far as diagnosis and treatment are concerned, different stakeholders have a different perception of the disease. Prevalence, incidence, and most importantly, severity, natural history management, depending if they are based on the hospital emergency physician room, depending if they are at the front line of an acute episode, or being GPs in their office, or belonging to food industry. So all these stakeholders are working in silos, and we need to harmonize their approach. The chair has already shown the EACI anaphylaxis guideline systematic review, and this systematic review went through getting evidence for what we know about the definition of anaphylaxis to optimize diagnosis. In 2006, operational criteria were put in place and recommended to improve the recognition of anaphylaxis in 90% of cases at the emergency department. But we had to wait 15 years before we had some studies validating this criteria, 2 retrospective studies and 1 perspective. And that means that the evidence is very low certainty of evidence. This means that we need further research, but for the current time, we can still use this criteria. But the difficulty in recognizing symptoms, that means the severity which prompts to use the self-injectable adrenaline, is still a patient decision, as we are not able right now as clinicians to provide an harmonized severity score. And so the patient should be aware of the risk, or understand the seriousness of the reaction, and decide by himself or herself what they should do. We know that, however, adrenaline is acting on all symptoms, and antihistamine only on the skin symptoms. So in the emergency kit, adrenaline is the top one drug that should be administered. But profiling the patients means to understand the risk, and most importantly, that those factors which act as multipliers of the risk of anaphylaxis. First of all, some allergens, which are the most important trigger factors for a given country, such as milk and peanut in the UK. The speed of response, we know well that for drug anaphylaxis, we have 5 minutes before the cardiac arrest, 15 for insisting, and 30 minutes for food. That some comorbidities, most importantly asthma and exercise, can facilitate the progression to a very severe, even fatal reaction. And that some allergens, such as the lipid transfer protein, storage protein, can put the patient at higher risk of a severe reaction. Overall, this can be considered when we prescribe an auto-injector, but most importantly, when we consider the possibility of access to the treatment, as there are some circumstances that should be considered when prescribing an auto-injector, and most importantly, when prescribing 2 auto-injectors. First of all, the remoteness from medical access, the difficulty to prescribe, the lack of education, and lack of availability in some areas, together with the psychological barriers which are preventing the patient from acting promptly. most importantly, the resistance to carry an auto-injector, not having memory of anaphylaxis, so denying having another episode, the fear of the needle, the lack of the awareness and education. Overall, we should design a tailored and personalized treatment. So what we need to do is to put in place strategies for improving adherence and ensuring safety, being effective and feasible. In the guidelines that the chair already showed to you, in the long-term management of anaphylaxis, the task force recommends that besides having the auto-injector, we must provide structured and comprehensive training to improve recognition of anaphylaxis and the use of adrenaline auto-injector in people at risk of anaphylaxis. Having an auto-injector and not being able to use it is useless. And in addition, using pre-medication with the sub-Q adrenaline to prevent anaphylaxis when snake bite antivenom is given, and most importantly, that school policies reflect anaphylaxis guidelines, and that we need research to understand which is the best intervention and the best legislation in school. We know well that we as physicians need education and training. So the task force suggests using simulation training and visual prompts to improve healthcare professional recognition and management of anaphylaxis in emergency situation. So the vision of an integrated care pathway approach is complex, as we need to be aware of the patient-specific complex interplay and to recognize a subject at risk of anaphylaxis not only on the basis of a clinical risk assessment but also on social circumstances and psychological barriers. And this can be done establishing a multidisciplinary approach where all the stakeholders are included. And most importantly, we need to understand better the epidemiology and practices, establishing a real-time surveillance program at the emergency department. We know well that there are barriers that hamper putting in place and implementing this integrated care pathway. Most importantly, the stakeholder resistance to adopt the best standards of practice, mostly for lack of motivation and knowledge and lack of healthcare professional adherence in guidelines. But how we can meet this resistance, establishing regular stakeholders educational program, taking advantage of digital platforms, and developing models for digital health on anaphylaxis in order to improve adherence and safety. There are also legal, ethical, and technical barriers. First of all, liability concerns, the fear of prosecution, for example, by teachers having to administer self-injectable adrenaline at school, and primary care having responsibilities in not prescribing. In addition, there are issues for data security for patient registries, and we are not familiar in implementing digital health opportunities. So we need to harmonize legislation and school policies across all European countries, ensuring financial coverage for training and for education, and not this being only a volunteer activity by patient organization. We need to have a registry for the disease, but these registries should protect the patient, so they should be compliant with the digital health certification. There are other barriers, for example, the lack of economical evaluation of anaphylaxis, which should be reinforced, as we need to have an estimate of cost, socioeconomic cost of having anaphylaxis and not having self-injectable adrenaline for saving lives. So this should be part of information to health insurances representative and policymaker, and also saving cost instead of considering to spend the cost for improving digital health tools for supporting treatment. Last but not least, I would like to mention the lack of reimbursement for self-injectable adrenaline in many European countries and in many countries across the world. The roadmap should consider supporting guidelines implementation and advocating for best standard of practice, and also to facilitate stakeholder engagement to ensure alignment and evaluation of tools. But we need to foster research for better understanding the disease, having registries, identifying a patient at risk, and biomarkers to personalize as much as possible the treatment, and putting in place novel treatments. The integrated care pathway is the vision and the mission of the Global Allergy and Asthma Network of Centers of Excellence devoted to anaphylaxis and food allergy, the so-called AnaCare. The AnaCare networks will act as a reference network for science, training researchers, and developing research consortia. The CME online training programs for health professionals developed for multidisciplinary learning groups will improve knowledge, and national networks for education at the local level, acting in platforms for fast communication flow regarding practice and research, will provide an information flow which is timely and adequate. So I would like that the patient and the physician can join this effort all together to improve the life of our patient. Thank you very much.
Thank you very much, Antonella, for a great presentation. You set out a very clear roadmap of what we should be doing. Perhaps I ought to add that the AnaCare centres are doing a webinar series on anaphylaxis that many of us are involved in, and so go and visit the site. So remember what I said about questions, go and find that tab, and please put in some questions for Antonella, which we'll tackle at the end of the webinar. But now we're going to move to Pamela Ewan, who is a consultant allergist from Addenbrooke's in Cambridge, is going to talk to us about supporting our primary care colleagues with at-risk patients. Thank you, Pam.
Thank you, Graham, for the introduction, and thank you very much to the organisers for inviting me to speak. And it's really great to know that there are a huge number of people out there listening to this. Sorry, a slight hitch with my slides. So, my declarations: I'm a co-founder of CAM Allergy, and this is just a brief outline of my talk. So I'll talk very briefly about anaphylaxis just to set the scene. Then I'm going to talk about management and pull on the BSACI and the NICE guidance and focus on adrenaline. And then the last part of my talk will be about how can you make your auto-injector prescription effective. So just a little background to start with on the prevalence. So anaphylaxis has been increasing since the early 1990s. And this first slide shows on the blue dotted line a 7-fold increase in admissions over a decade up to 2000. And if we go on to the following decade, up to 2012, this is now admissions in England with anaphylaxis, but only due to foods. And here you can see a doubling of the admissions over that period. And there is lots more data, including more recent data from NHS Digital, showing the increase in anaphylaxis and consequent admissions or A&E attendances continues to go up. Now, if we look at causes, this is a very old slide, but I've chosen it because it's quite clear in terms of the way the causes are written. But the 4 big causes of anaphylaxis are foods, bee and wasp stings, drugs, and idiopathic anaphylaxis. Now, idiopathic, remember, is non-IgE mediated and occurs spontaneously, whereas the others have triggers. And there are many, many studies of causes, and the breakdown roughly you can think of as approximately evenly divided between those 4 big causes: foods, venom, drugs, idiopathic. But if you look at the causes split by age group, you can see a different figure. So if you look at the bottom row of this slide, you will see 3 of the 4 big causes. This is data from Richard Pumphrey, and he didn't at that stage include idiopathic because it was a bit less recognized then. But if you look at children, you can see in the small children, it's all food, and in the bigger children, it's very dominantly food. So food is the big cause in children, whereas the 4 other causes are distributed in adults. And Antonella just touched on the clinical features. And of course, there is a range of features in anaphylaxis, not all of which need be present. And I think there is a simple way of breaking this down when you're thinking of it, when you're seeing patients. So on the first 2 lines of this slide, these are cutaneous features. Then the next pale pink block are the respiratory features, which in severe reactions are very severe asthma with dyspnea or laryngeal edema, where basically asphyxiation is occurring. And then the third big group shown on this slide in red are the features of hypotension. And I like the UK Resuscitation Council definition of anaphylaxis, which is quite simple, which is an acute, sudden onset, severe reaction with either severe respiratory difficulty or features of hypotension, usually accompanied by skin changes. And that encompasses in one sentence the kind of range of things you can see. Now, if we look at the severe feature in relation to the cause, you can see it differs according to cause. So that we know that with food anaphylaxis, the key feature is respiratory. So, for example, peanut anaphylaxis, their main dominant and severe symptom will be airway difficulty, and that can lead on to asphyxia and respiratory arrest. And any hypotension in that scenario comes in secondarily and later. Whereas, by contrast, with parenteral drugs or with venom, which is almost like an injection, a bee or wasp sting, the dominant feature is cardiovascular. So they have hypotension, giddiness, possibly loss of consciousness. So the next thing I want to talk about is timely administration of adrenaline. Now, this study on this slide is a very old one from Hugh Sanson, but makes a useful and important point. This was in a very small group, 13 children. Most of them had asthma, but looking at when adrenaline was given, of the 6 fatal reactions, half of them had auto-injectors, none had it available at the time. And the adrenaline was given very late, 22 up to more than 2.5 hours from onset, giving the first adrenaline. If you look at the near-fatal reactions in this group, most of them received adrenaline in the first 30 minutes. Still slow, but at least a lot better than the top group where there was tremendous delay to adrenaline. So early adrenaline is important. And just emphasizing this point from a different perspective, on this slide, if you look just at the figures in the red box, this is data from Richard Pumphrey, who very carefully studied fatal anaphylaxis by getting data from the coroners post-mortem. And you can see in that red box, only 13% of these patients received adrenaline before cardiac arrest. The others either didn't ever get adrenaline, or 48% had it after arrest. So again, late adrenaline. And this is where, of course, the adrenaline auto-injectors are a wonderful thing, because they're with the patient at the time the reaction starts, and should, if we get everything right, be able to deliver adrenaline very early. And we know, of course, that reactions are much easier to reverse if adrenaline is given early. So turning to management, this is taken from the NICE guidelines on anaphylaxis, which were published in the UK in 2011. And in the blue box, I put the sort of things that would need to happen in primary care. Some of them might happen in the emergency department, but this is after anaphylaxis in the cold light of day. So GPs should be refer in order to get a diagnosis and a management plan, but they should also be prescribing an adrenaline auto-injector. That might have happened in emergency department. Importantly, there needs to be education about what is anaphylaxis, what are the danger features, and how to use adrenaline auto-injectors. So these were very important points, and still, they're now 10 years old, still not completely or properly in place. Now, BSACI produced a guideline called Prescribing an Adrenaline Auto-Injector, and that was published in 2016. And the first thing to say, and I think my slide has gone wrong a little bit, but the top 3 lines should be in that blue box. So you should not ever think of the auto-injector as a standalone. It should be part and parcel of some of those things just recommended in the NICE guidance. So the patient should now be aware of the risk, they should have had education, they should be trying to avoid the allergen, and they should know that they should be going for early self-treatment to lead to easy reversal. And also the auto-injector is a first aid approach. It's not the only thing. They dial 999, they seek medical help. It's gaining immediate control to be followed by other management. And what BSACI recommended was that patients should be managed following a risk assessment, assessing the risk of anaphylaxis and likely outcome. And so they recommended rational prescribing based on this risk assessment, where some patients might have no adrenaline auto-injector, others might have 1, others might have 2, and so on. But they felt that for the majority of patients, 1 would be suitable. But of course, there are exceptions, and these are all set out in the BSACI guideline. MHRA produced guidance, as Graham alluded to, and their recommendation was for 2. So we have overlapping and slightly conflicting advice. Now, who do you need to prescribe an auto-injector for? Well, I've tried to simplify this down from the BSACI recommendations, but clearly anaphylaxis, although there will be exceptions. If you'd had anaphylaxis to an injected drug, say a neuromuscular blocker at the beginning of anesthesia, you don't need to carry adrenaline. And so there are some exceptions, but on the whole, anaphylaxis. A second very important group, particularly, well, very much in adults, but possibly a little in children, is angioedema of the airway as an isolated presentation. So we see large number of patients now with tongue angioedema. And if that is bilateral and big, it can cause asphyxia, and adrenaline is essential. So there's a particular tongue swelling treatment plan that patients carry with various treatments, because the degree of tongue swelling can be very variable, but including adrenaline. Then there's another big group, those at risk of anaphylaxis. These people who've never had it and might have a much more moderate problem, but it's considered they should carry adrenaline. And again, that is explained fully in the guidelines with examples, but one might be a systemic reaction to a bee or wasp sting, which was mild and which in itself, if that repeated, would not require adrenaline, but there is a risk, and so patients should carry adrenaline. And a raised baseline tryptase, which I'm not going to go into in this presentation. And in the UK, we prescribe lots of auto-injectors. The data a few years ago was that we prescribed many more per capita than other European countries. And one area where we see a lot of patients being prescribed adrenaline, but it's not needed, is urticaria and angioedema, unless the angioedema involves the airway. There is a difficult one where patients might have a history of some urticaria or some angioedema, and then they say, in this last episode, I had a slight feeling of throat tightening or just an odd feeling in my throat. That is very difficult to assess and put a risk on. And so we say not usually, but consider, and it has to be put in the context of the whole picture. Now, here are the adrenaline auto-injectors. So on the left of the slide are the two that we have available in the UK. So we have Jext on the left and EpiPen with the blue caps alongside. And so these are the only two we have. They're cartridge devices. On the right-hand side, you can see Emerade, and at the bottom, Anapen, and these are no longer available in the UK. Emerade was discontinued. Anapen is available in, I think, in certain other European countries and in the Republic of Ireland. So what is important is the technique of administration of our two devices, Jext and EpiPen, differs. So with Jext, you will, I'm sure you will know that it's this swing and jab. If I do a demonstration, so you've got your pen, you're slamming it onto the leg, and then it activates. With Jext, it's different. It's laid on the thigh, and then there's a push, and it's much gentler, and patients find that, I think, less frightening. The fear of the needle, if you're doing the stabbing motion, can inhibit some patients in continuing to push hard. So patients find that a plus. Now, this slide, I think I should have called myths rather than saying myths in primary care, because these are general myths, but I want to dispel a couple of myths if I can. And the first is about needle length. So there was a view going around that the longer the needle, the better. But there is quite an amount of data showing that Jext and EpiPen, which are both, as I've said, cartridge devices, have got this propulsion and compression force which delivers the adrenaline well beyond the needle length, so it goes into the intramuscular compartment. And the regulators have required all the companies making auto-injectors to perform studies of absorption of adrenaline, and these have shown that Jext and EpiPen, which have a shorter needle than Emerade, gave superior adrenaline levels to Emerade. So that is the story about the needle. Further, MHRA have produced this statement, which I've quoted here, to say there is evidence to suggest from the PK studies that one EpiPen or Jext, 300 micrograms, 0.3 of a milligram, is a suitable replacement for the Emerade 500. So these are important points to bear in mind. Now, the huge difficulty we have, despite all this prescribing of auto-injectors, is unfortunately that patients are unable to use them. And this is data from a national audit by the BSACI nurse group done by Deborah Marriage and colleagues. And if you just look at the green lines, that'll give the main message. So in adults, it was found that 31% didn't carry their auto-injector, and in 33% it was out of date. So astonishingly, almost 2/3 of patients not having a device which would work or could work. In children, I find it even more surprising. 29% of children not carrying their device. That seems astonishing. And in 11% of children, they were carrying an expired device. So 40% of the children prescriptions were of no value. So a huge waste. We're prescribing, but we're not getting the patient understanding about the need. And I hope Matt Doyle will not mind if I just give one slide from the longitudinal prescription data, which he's going to present in much more detail. And so it seems this is a very recent study. It's going to be presented at EAACI this year. 30% of patients carrying expired devices. There has been, this is UK data now, there has been a threefold increase in generic prescribing. And that's a big concern, because unless it's followed by training for the particular pen, whether it's Jext or EpiPen, those devices won't necessarily be, the patients won't necessarily be able to use them. And a huge number of prescriptions have been written for Emerade in the 6 months after it was withdrawn in the UK. So again, we need more knowledge across the sector on these auto-injectors. So the big message I want to get over is that prescribing an auto-injector is not sufficient, and unfortunately that's often seems to be the belief. And we have to train and retrain in order to de-risk the patient, make them safe. And it's not just a single training that's required. And how to achieve this slide now is not from a guideline. These are just my own thoughts. But Antonella has talked with about some of this, and obviously it may come into guidelines. But I think the first thing is training a patient has got to be training in the use of the auto-injector has got to be second nature, both to the patient and to the trainer. And I think too many times we ask people or expect someone else will deliver training, and actually they're not that sure themselves. So it's something that we need to train the trainers and enable them, empower them with the expertise. And it's important that those skills are maintained. So it's not very useful if someone does one every 6 months. It needs to be something that is more focused into a group of practitioners. I think we've learned quite a lot from COVID. Over the last year, we've been doing most of our consultations by phone, not face-to-face, so we can't train the patients in adrenaline auto-injector use physically. So we've had to resort to the app, the trainer pen, things that we used to tell them about, but things that we are now relying on and really emphasizing. So it might be in the UK, for example, where we have asthma nurses, that we could have those nurses becoming the auto-injector trainers. Perhaps it could be done on re-prescription, but we are aware, of course, that primary care is under huge pressure, and this would be yet another thing. I've lost the control to forward my slides. Could you forward the next one? Thank you. So this is just to finish up. So practical training is essential. There are the videos on the company websites. You've seen one of those already. There is a trainer pen, a dummy pen available to practices and to patients. And so we have to push more for use of these devices. We might have designated people in practice. And of course, there is the on-device instruction, which I've put in pale grey because it's not the time for a patient to be reading that. Next slide, please. So what can we do? Are there things that we can do to help primary care? Well, I think from secondary care or from hospital discharge, we should be clear which auto-injector has the patient been given? Have they been trained? Do we want primary care to do ongoing training? What is the plan? It's a bit like Boris Johnson in Number 10, chaos, where no one knows who's responsible. It's this, that, way, up, down. We need to be a bit clearer because the patient falls between these different groups of people who might be helping them. I do think we have to make the patient more responsible than we have in the past and ensure that they do take responsibility for ongoing training, or the parent, and direct people to all the resources we've already talked about. There should be more study days for nurses and GPs, and I think that is already happening, and they also can be directed to the right resources. Next slide, please. And that's just a summary of resources. And I would draw your attention to the fourth bullet point down. The BSACI are shortly going to publish primary care guidance led by Liz Angier and Deepa Chaudhry, which is, I think, near publication. And that should be a very valuable resource for primary care. Thank you.
Thank you very much, Pam, for an excellent presentation. I'd encourage you to ask questions. There are quite a few in that we've received, but please ask more. Pam, we'll come back to you with the panel discussion at the end. Thank you. So we're now going to get the primary care view. So Matt Doyle, who's a GP with special interest in allergic disease from Jersey, is going to talk to us about where do the responsibilities lie from a primary care perspective. Thank you, Matt.
Thanks very much, Graham. Thank you to the organisers for having me and for everyone who's out there listening. I'd like to say up front also a great thanks to my colleagues Sarah Lacria and Shelley Dewar, who've done an enormous amount of work in gathering the data that we're going to talk about this evening. So the question is where the responsibilities lie, and just to say up front, the responsibility very much lies with the prescriber. If we prescribe a drug or a device as a doctor, the responsibility lies with us to make sure that that's done safely, it's done effectively, and that the person we're giving that drug or device to understands what it is for and how to use it or how to take it properly. So to look at this in more detail, we're going to look at three sources of information. We've got the longitudinal patient data that Pam alluded to, and Pam, you're entirely forgiven for stealing some of my thunder. We've got the GP survey that was carried out earlier in this year, which gives a real insight into prescribing habits. And along the way, we're going to dip in and out of the Anaphylaxis campaign's quality of care survey from a few years ago, which shows some of the similar points have been made before and are still being made now. So the longitudinal patient data gives an enormous amount of information about the prescribing and about the handing out of adrenaline injectors across the UK. And it gives us some quite important insights. If we look at the number of devices, majority of patients are being prescribed 2, as the MHRA have recommended, but a good proportion still only being given 1. As has been alluded to, we've got a third of patients carrying around expired devices, and we've got this huge increase of generic prescribing. So by that we mean instead of writing a prescription for an EpiPen, we would write a prescription for adrenaline injector 300 or something like that. So in that instance, a pharmacist could give an EpiPen, they could give a Jext, depending on what they have in stock. To that end, we've got nearly a quarter of patients carrying more than one brand, and as Pam alluded to, an enormous amount, 23,000 prescriptions that were written for Emerade after it had sort of been recalled and been taken off the market. So we know that in primary care, and by primary care I don't just mean GPs, we're talking about our pharmacy colleagues, other healthcare professionals working in the community, there's still a big problem out there. So the survey was done from December, completed in February, quite a wide spread of answers from GPs across the country. So 500 GPs completing it, and I'm just going to skip forward just to this slide, just showing you the spread of where these GPs were from. So we had a good UK spread in the answers that were given. They looked at a number of topics and what we're going to do, and we're going to rattle through fairly quickly because there's quite a lot of stuff here, but hopefully just pulling out the salient points as we go. So we're looking at how knowledgeable are the GPs in the correct use, what do they think their patients' knowledge and capabilities are, what's the support like for patients and what can be improved, how are people being followed up, this important aspect of switching, which we'll talk about in some more detail. Who's got the responsibility? Is it the GP's responsibility? Is it secondary care's responsibility? And are our GP primary care colleagues and pharmacists feeling supported? So if we start with the training on devices, so this was a question in the survey. Please find below some patient advice for administration techniques and time for 3 different adrenaline injectors, and then allocate each piece of advice to the right injector. And what you can see is that nearly half the responses were incorrect. Not hugely surprising, because it looks that a lot of the training is just not happening, and one of the reasons is always when trainings are given because it's lack of knowledge by the person being asked to do the training. In 20% of cases, however, all the answers were correct, which is a small amount of reassurance. The work done by Christina Jones, Helen Smith, looking at this in the past, again, made much the same point. So 21% of healthcare professionals were able to demonstrate the proper technique. But the key point here is that when you do a before and after training, you can go up to 65%, which I think we've all seen suggestions like this before. So if we go on to how GPs feel about their patients, and the question here, thinking about the patients in practice, how confident do you feel about the ability of the patients to manage the following acute events? And anaphylaxis here is mixed in with another 4 emergency events, so an acute attack of asthma, hypoglycemia, an ischemic heart disease, attack of angina, chest pain, or an epileptic seizure. And you'll see that the confidence rating for anaphylaxis was the lowest. There is a reason for this, and this will come up later again. There's a thing in general practice in the UK called the Quality Outcomes Framework, which is abbreviated as QOF. It's a way that GP surgeries have been funded for nearly 15 years now. And there are markers for different conditions, and you have to essentially tick boxes to show the care that you're providing in those areas. Ischemic heart disease, epilepsy, asthma, and diabetes are all included in the Quality Outcomes Framework. There are data points for all of those. So often patients are asked to come back in for annual review so that this data can be gathered. That does not exist in the QOF for anaphylaxis. So the major factor for people not being able to use it is, GPs believe, is training. You'll see the top 4 answers to this question at the bottom. A proportion of patients unable to correctly use the injector. What are the main reasons? Training is the first sort of biggest 4 answers. We do have the issue of anxiety, which is the 6th answer there, and we've got switching being mentioned again. Poor patient understanding, sort of lower answers, but the key top point here is training. So GPs are reporting a low confidence in their patient's ability to manage it. They're acknowledging that training is the issue, as well as infrequency of use and anxiety. So once again, this point about training the professionals and having the patient taking part in that training is so crucial. So having identified the gap, how are we giving them help? So what support is given to patients in practice who are at risk? So what's provided, who gives that? 20% of GPs reporting that it's nothing. We've got a wide range here. We have websites, videos, dummy pens is a sort of 4% answer. Sadly, dummy pens, demonstration, and face-to-face all sit right down at the bottom at 4%. Leaflets and written info are the highest answer, though I'm not quite sure what leaflets or written info people are referring to. Anaphylaxis campaign, so this is from their survey a couple of years before. made exactly the same point. 66% of patients who presented to GPs were saying they weren't signposted to appropriate resources. So a point we'll come back to again later, but the GPs get higher ratings for things that they're reviewing annually, which is not surprising. We've got 20% of GPs saying that there's no support available, and we've also got the fact that additional support to patients is often not given by GPs, but often by practice nurses who are extremely able and often very highly trained individuals. If we look at follow-up, and again we've touched on this with the information about the quality outcomes framework, again here you're looking at comparators with diabetes, ischemic heart disease and asthma, all of which have an annual review that brings funding into surgeries. Anaphylaxis doesn't really figure, no regular follow-up for anaphylaxis, which was the highest answer for that one. We had an annual as the next highest, and then 6 months very low, don't know, even higher. GPs who did do their own training, so if you look at the questions at the bottom, questions 1 and 4 in the survey, thinking about the patients in the practice, how confident do you feel about your patient's ability to manage it, and how often the people followed up? There's very much a link here. So we know that GPs who do their own training with patients are unsurprisingly more confident in their patient's ability to manage an acute episode. So 40% of GPs reporting patients followed up once a year or more. So 60% essentially saying follow-up is, whatever. And the initial training follow-up being performed in primary care by the practice nurses. GPs who did their own training or who had their own practices doing the training, essentially more confident in their patients' abilities. So switching is this issue of a patient being given a prescription for a replacement or after their first device and finding they've been given a different device. It is now slightly simpler in the UK because, as Pam alluded, we have the two devices, the Jext and EpiPen. But what you'll see is that 34% of GPs are saying this does happen often or very often, and then sometimes being the highest answer at nearly 45% of respondents. So switching is a very common thing, and it's worth thinking about why it might happen. I'm going to just skip forward a slide just to talk about this tragic case, Shantri Teray Thomas, who died from her nut allergy. One of the points that came out of this was, again, about prescribing two pens, about training, but also you'll see this comment at the bottom, the GPs involved relied on the advice given by the CCG, which in this case was wrong. What this comes to is a bit of software called Script Switch. Script Switch is installed in about 4,000 GP surgeries through the UK, so it's about half of them. And it's a prescribing advice software, and it's generally used to reduce costs. So it will look and see what you're prescribing to a patient, and it will look to see, would you save some money if you prescribe this generically, or sometimes even branded. Sometimes it's cheaper to prescribe the branded than the generic. And it will always try and default a prescription to a generic rather than a branded, so that the cost can be kept as low as possible. Now, in this particular case, Script Switch, which was being used by the local clinical commissioning group, went for a change in the pen, which was the problem. Going back one slide, so GPs reporting patients most often directed to pharmacists or provided with no additional support in the switch. Again, the reason for this is that the majority of GPs will issue the prescription, but the patient will then take this to a pharmacy. And it may be a local pharmacy, but it may be one of many local pharmacies. And the GP who's done the prescription has no line of sight on what that patient is actually given when they take the prescription to the pharmacy and are given a new device. So the GP doesn't know if the patient had EpiPen and was given Jext or vice versa, and unless they are a dispensing surgery. So some GP surgeries have their own dispensing pharmacy within it. In that circumstance, they've got a degree of control. But in the majority of cases, the moment the prescription is in the hand of the patient, what device they are given is out of sort of line of sight of everybody but the pharmacist. So that puts an additional bit of pressure on our pharmacy colleagues, who naturally would assume the patient is trained in the device they're giving. So again, going back to the anaphylaxis campaign survey, 79% of patients saying they weren't shown how to use the adrenaline injector when getting a repeat prescription. And the crucial word there is repeat prescription. It's a really useful moment to reiterate training, to do training that has not yet been done. But at the moment, it generally seems that these repeat prescriptions are just handed out. And it's often done remotely, of course, through, you must remember this GP survey was done through the COVID period when a lot of remote working was happening. A lot of remote prescription ordering was happening at the same time. So switching is a common event. So almost all GPs reporting switching takes place, and some saying there's no additional support after the switch, most often the pharmacist who the patient is going to be exposed to, because that's the point at which the switch is made. So healthcare professional responsibility, this is the important question on this, I think. You've told us patient prescribed an auto-injector received training when they're first prescribed. Who normally provides this training? And you'll see there's a mix of responses, but there's one significant outlier, which is specialist centre. Now, we see this in general practice with a number of prescribable drugs or devices. So there is what we call shared care, and there are shared care pathways for a number of drugs. I think a very good example is a drug called methotrexate, used to treat a variety of conditions, including rheumatoid arthritis, psoriasis, other types of inflammatory arthropathy. And in those circumstances, the specialist initiates the treatment, the GP takes over the prescribing, but there is always a problem in primary care that methotrexate needs regular blood tests. And we often find in the first year that the patients are being given the methotrexate, that there is a moment where the regular blood tests fall off the map a little bit. And that's because the GP thinks that specialist centre are doing it, specialist centre think that the GP is doing it, and the patient, the poor old patient, gets lost in the middle of it. So who should take that role? Well, GPs were fairly adamant here that the leadership role should be from the specialist centres, which is, of course, absolutely right in the initiation, but cannot be correct in follow-up repeat prescribing. It has to be a shared care, and primary care does have to take responsibility. I mentioned at the beginning, where does the responsibility lie? As a GP, if I prescribe a patient something, the responsibility lies with me as the prescriber, not with the person who started the treatment maybe years before. So just to run through some of those, 60% GPs saying specialist centres should take the leadership. We know that training for other conditions does occur in primary care, and we know that the initial training is done by specialist centres. However, because of switching and because of that chance to reiterate training at the point of view of repeat prescribing, some of it has got to move, or the majority of it's got to move into primary care. So finally, just to finish off, and I know we've whipped through this fairly quickly, where are people getting training from? So what do GPs want? Device comparison information was top of the list. I know my colleagues, Pam in Cambridge, they have such a thing has gone out over several years to general practice. Training videos, dummy devices, online training, etc. is all the obvious stuff. So it's agreed by general practice that we don't get the training. We know it's the most important area for improvement. We also know that because we don't get the training, we then have a low confidence in our patients' ability to use the devices. And there's big gaps here. There's a big hole that we can fill with education. So here's the overview, and it's the poor patient falling in between. It's the patient who has a healthcare need, and we are not necessarily meeting it in primary care. I would argue that it's not just with adrenaline injectors. I think colleagues who deal with patients in asthma would say the same, with patients being given new asthma devices that are completely different from their previous inhalers and getting no training on them. It's also the case with other injectables that are used in other specialities of medicine. But in most cases, with things like hormonal treatment for prostate cancer, it's not necessarily going to be as severe if there is confusion about how to give it. Plus, we're talking about far less children being affected. And this was one of the comments from the survey, which I think is very well made, and I think sums the entire thing up. So I'll leave that there on the screen. Thank you.
Thank you very much, Matt. Great presentation. It's good to see what the view is from primary care. So I'm going to ask all the presenters to appear on the screen, and then we're going to go to Q&A. We have lots and lots of questions. So the first question is going to be for Antonella. So Antonella, do you think that improved training will directly lead to better carriage of the auto-injector devices?
I am pretty sure of that, as I have experienced that in my center. But training means also addressing psychological barriers and teens' attitudes. And this means that when we provide the training, we reschedule training quite shortly. And it is a huge effort for us. And we do that with our psychologist. So we offer a regular psychological support to the patients. And this has improved very much their carrying auto-injectors. But we have never evaluated the cost of that. And so is a matter of cost effectiveness, in my view.
Yeah, thank
However,
you.
it works very much.
Thank you. So on a very similar theme, this one is for you, Pam. What do you think prevents patients from using their adrenaline earlier?
Well, probably lack of knowledge, combination of factors really, lack of knowledge of the key symptoms, and this should be written down ideally on a treatment plan that they should carry to reinforce what they've already been told. And possibly in some patients, fear of using it. They think, well, let's just wait a bit longer and see.
Yeah, thank you. I completely agree there. So, and this is also one for you, Pam. So there's lots of resources out there now, which is in response to the EMA request. What do you think should our patients be using? Should they be using the online videos? Should they be using the trainer devices with leaflets? What do you think is most effective?
I think they need to use all of these. I think ideally, the best thing, and which we haven't been able to do during the last year because of COVID, is practical training in the specialist centre, followed by using the video, using the app, using the trainer pen. We suggest all of these things are needed, and also that they're needed repeatedly. So I always say to patients, every 3 months you must get your pen out, practice, look at the video. It's got to be second nature. Training once is no good. Well, it's obviously better than nothing, but it's not no good. But you need to make it second nature to the patient, so it's not a panic, just like it's second nature to the people who do a lot of training.
Thank you. So as you see, we have lots and lots of questions that are coming in. The next one isn't directed to anybody in particular, but is probably, Antonella, this is probably a question for you to address. So how can we better educate our teenage patients? And there's obviously issues here around stigma of carrying auto injectors, and might schools be more helpful?
Yes, I partially addressed that in my first reply. However, we are trying to organize a focus group with adolescents and to reinforce their carrying the autoinjector. First of all, the most difficult part is for them to carry two autoinjectors, as they are big and they feel a bit uncomfortable. So we asked them if they forget to carry their iPhone or their mobile phone, and this never happened. They look at you, are you crazy? Never. The iPhone and my mobile phone is a second skin for me. And we reply, yes, and the auto-injector should be your second skin before your mobile phone. Using what was effective in our experience has been having regular intervals every 6 months in teenagers who are more reluctant, and the focus group with the psychologist. Again, I don't know how many centers can afford a psychologist for these issues on a permanent basis, and it should be nice to evaluate the cost effectiveness in an overall cost effectiveness evaluation of anaphylaxis. But in our experience, this worked very well.
Thank you, Antonella. So there's a series of questions for Matt. I think we'll go to this one first of all. So this is a comment. So the problem is in primary care that we do not see these patients. They just collect their repeat prescription. Do you suggest we schedule checks before the release of the prescriptions? And I think you do this once someone's had, and is it 10 salbutamol inhalers? They have to come in for a check before you give any more?
Yeah, I think it may be lower than that. But the wonderful thing is with salbutamol is a good example. Most of the GP software packages give us alerts. So they will say, you know, prescription flashes up for a patient requesting the other 16 blue inhalers, and an alert will come up saying this patient has, you know, potentially overusing their salbutamol. It should be a relatively simple thing to be able to put, even if it's just an annual box on those alerts to say, you know, has this patient had training? When was their last training? Or when did you code the last time they were trained in their adrenaline injector? For us to create in primary care a code and then just a one-off tick box, it would just act as a reminder, an aide-memoire to running through things. And I think even if it was just a phone call to the patient to say, I've done your repeat prescriptions, you know, are you aware of this app? Are you aware of this video? Just being able to signpost.
Yes. Okay. So I'm going to admit that this is a question from me. So we all know that most adult allergy clinics operate a one-stop service. And by that nature, ongoing education, re-education, retraining is delegated to primary care. And I wonder whether how Pam and you, Matt, felt that we should be trying to implement this more effectively going forward. You may not have a 1 minute answer you can give me, but I thought I'd fire the question at you anyway.
Do you want to go first on this one, Pam?
No, you go first. I was reading a question, actually, partly, I have to admit, during that question.
You know, it comes back to this shared care. We've got to work closely in hand for the care of our patients. And I would again stress that when I sign the prescription, the responsibility lies with me legally, and it relies with me as a clinician. And I cannot abdicate that responsibility. General practice, we're hammered. And we're particularly hammered at the moment. I'm a full-time GP. You know, I do 5 days a week in general practice. And I've never known the level, even here in quiet Jersey, of the workload. But there are, you know, we know the importance of these things. And we also know, I think most crucially, there is a hole at the moment for this. And it's something we can address. So we've had holes in other areas of patient care and we've addressed them. This is just, I think, the next one for us to look at in primary care.
So Graham, what's your point? Was it about the integration between care across primary and secondary?
Yeah, I mean, because of the way allergy service is set up on the adult side, so training and retraining is delegated to general practice. It obviously isn't happening as well as we'd like to at the moment. I'm just wondering what your thoughts were in terms of how we go forward, how we improve the situation.
Well, I think there is definitely an onus on the specialist centre to deliver training when they see the patient, whether that's one-off or repeated at every opportunity. I think we need to communicate better with our primary care colleagues and be clear what we've done and what we would like them, if they can, to take on. That would help. Be clear about devices. And I think in the midst of this, we should increase the responsibility on the patient, because we can do so much, but they need to, I think, step up. And if in the case of a child, obviously the parents, but I think we need to make that clear as well and have a triumvirate really, and where everyone is contributing, but you have to be very clear about who's doing what.
So, Matt, you already commented that primary care is overrun at the moment with work. So, what would you say to one of your colleagues who hasn't got enough time, hasn't had any training on anaphylaxis recently? What would you say to them to encourage them to come to a webinar like this, or use one of the online resources?
They would have my sympathy, because I know exactly how they feel. GPs, of course, have to be the managers of all fields of medicine, and we have similar priorities and difficulties across the field. I think this is an area of quite a small patient group, but a very important one. I would also say that the training, unlike a lot of things, the training is suddenly out there. When I started in allergy, there was very little training, either online or otherwise. Now there is a wealth of education that is out there. It's just knowing how to access it. And through the primary care group, the BSACI, we can always signpost people to education. GPs need to perform a certain amount of CPD per year. And, a quick 3/4 of an hour on a Saturday morning looking at an online thing just ticks one of those boxes, even if it's only for that year that you just decide that anaphylaxis is going to be one of your CPD points for 2021, then I think that's enough. But I sympathise, it is very difficult.
Okay, so a question for Pam. We do rely on emergency responders in the community. They're local, they have defibrillators, etc. Should they have adrenaline auto-injectors?
I think they do, don't they?
That was the question. I don't know. Maybe they don't in all areas of the world.
Well, the paramedics certainly do have adrenaline, and so, I mean, quite often we see patients who've been given adrenaline in the ambulance on the way to the hospital. Whether they all do, I don't know, but most of them, I think, do.
I think they're drawing adrenaline up from ampoules and giving it in syringes in general. At least that's the feedback I've had from paramedics that I've talked to. Should they have auto-injectors?
Well, I suppose it depends on their training and what their knowledge. I mean, is the inference here that this would be simpler and easier, rather than having to draw up the appropriate amount for an adult or a child? Yeah. They must have a lot of training on anaphylaxis and all the emergency things. So I guess they know all the doses, but I don't have a strong view on. I think without knowing enough about their training and their knowledge is pretty good, I think it's a bit difficult to comment on that.
Yeah, they're certainly good at giving adrenaline in the right situation. And then a really quick last question for you, Pam. So we have BSACI anaphylaxis action plans for children. The question is, are they coming in for adults?
Well, we don't actually use the BSACI one because we started our own emergency treatment plans many years earlier. And so right from the start, we had an adult and a child one. So we have one for adults, one for child, but that's just used in our department in Cambridge. But it would be very simple to devise one for adults. We separately have another treatment plan, which is for tongue swelling or laryngeal edema. So that's a different treatment plan, which is oral antihistamines, prednisolone, and the third step is auto-injector. And they can, of course, go in with the auto-injector as the first step if they have very severe bilateral tongue angioedema from the start. But some of these patients develop angioedema during sleep. That's a very common picture. So they wake up at 2 a.m. with tongue swelling. And if that happens, it's more advanced than catching it early when antihistamines and steroids usually work. So we have a variety of treatment plans, but all of them include adults as well as children.
So perhaps the BSACI needs to have a look at your adult plans and see if we can turn that into something that we could use nationally.
Yes, I'm sure other specialist centres also have their own treatment plans, so it won't just be one place now.
Great. Okay, so I'm going to draw the questions and answers to an end. Thank you very much for all the speakers for answering all those questions that I fired at you so quickly. If I can just go to the slides, thank you very much. So I hope you've enjoyed this evening's webinar. I think you've got a very good overview of anaphylaxis. You've heard how its impacts on family. You've heard a view from a tertiary centre. You've also heard a view from the primary care aspects. And as you see, it's actually quite a challenge to actually manage these patients. They have hopefully quite infrequent events, but they need to know, be carrying auto-injectors, they need to know how to manage a reaction and use their adrenaline timely, and they need regular re-education, which is perhaps a problem at the moment. So that leads me to just say thank you very much to our speakers, particularly to Antonella, who's joined us from Padua. But I believe it's much easier to join from Italy these days than it used to be a year or two ago. So, and also thank you to Pam, and thank you to Matt, and thank you very much for ALK for organising this webinar.